Right, good evening, doctors, and welcome to the third of the Genoa OMG CPD events. I have the pleasure this evening in being joined by Dr. Brad Byra, who will be addressing us shortly. I know that a lot of you in the room have already been in attendance at a number of the events, so I won't bore you with what it is or too much of what it is that we do. But as my 30-second introduction, Genoa Underwriting Managers is a liability-focused underwriting management agency that focuses on professionals like yourselves. We've been doing this for many years, and we are regarded as experts in the field. Brad, before you kick off this evening, I'm going to hand over to Dr. Serpentine. Dr. Serpentine, thank you very much for the opportunity again to be able to join and address your members tonight. And I hope that everyone finds the presentation to be as interesting as I have when I've listened to it in the past. Thanks and have a great evening.
Thank you very much, Brad and the team of Genoa. Good evening to everybody. Thank you for joining us again this evening. We appreciate that you take time out of your personal life to attend these meetings and learn a little bit of something. We appreciate that. We just want to say, yeah, best of luck to everybody at this stage. It is still tough times out there, but at least the data that we are getting in is showing that practice is busy picking up. The last set of data we had showed that the June figures were only 2% below the figures of June 2019. So definitely there is a bit of an increase. We'll have to see what happens in July because traditionally everybody takes off in July to go on vacation. I'm not sure whether that will be happening this year. So it'll be interesting to see what the July figures look like. But yes, in general, it does seem that the industry as a whole, ophthalmology, is managing to pick up. There are obviously individual practices that are still struggling a bit, but you're welcome to contact us if you need some additional assistance with that. Yeah, and so from our side, thank you very much to Genoa for assisting us with this meeting, and for Brad for the talk that he's going to give, and thank you for Michael, John, and everything for making the arrangements for this. So yeah, then from me over to Brad, and thank you very much. We look forward to your presentation.
Johannes, thank you. It's very lucky to be on screen with you guys again. I'm going to pull up today's presentation, and while I do so, I'm going to acknowledge that it's been an absolutely spectacularly beautiful day in Cape Town today. So for those of you that are looking to buy a house, these are the kind of days where you would do it here. Of course, in the southwest, it starts, or the southeast, it starts to blow, and then you realize why your house has a hurricane-grade roof. By introduction, I know that there are some familiar names that I've seen on the schedule. It's always half delight, half surprise that you've come back to listen to me again, but I'm very happy that you have. The best way to do this, I've learned in the past, is that if you've got a question, put it onto the chat bar. It'll come up for me. I'll see what it is, and I'll try to answer the questions in real time. The purpose of today's presentation is not to talk about what medications you should be prescribing for which conditions. Rather, it's to talk about where are we in terms of our safe medical and safe medicine practices. So I'm going to share with you in part some of the presentation that I do for SADC and SADC countries relating to medication safety through the World Health Organization strategies. I'm also going to try and make this as reflective and useful for you as possible in terms of how your practice works and what you're doing in your practice. We've spoken before about checklists, and I'd like you to take some time in the reflection of this to say, do I do these kind of safe medical procedures when it comes to medicine? Do I manage my medicine as well as I might? Do I manage the communication around my medicine as well as I should? Do I keep the records of my medicine for my patients as full as they might be? So those are your reflections for tonight, and hopefully as you leave here and segue out of your day into a very pleasant evening, we'll have provoked some thoughts that have given you one or two practice enhancement tools. So when we go on, we talk first about moral hazard. I did this presentation this morning for a group of occupational medicine practitioners. And the comment on the moral hazard is I suppose you could say tongue in cheek, no good deed goes unpunished. You do something because you think it'll be really good and it'll help other people, but the action of you doing it results in an unforeseen adverse or negative outcome. We saw this very early on in terms of HIV and AIDS, where we found that at that time, and this was the late 1990s, that a person who had a CD4 count of 400 went to 300, went to 100, went to 50, and very quickly after being diagnosed as being HIV positive, these patients deceased. And so we put insurance covers into place so that the cost of their funerals would be managed. The consequence of that, of course, was that people became HIV positive and seroconverted because the value of the policy payout was significant enough to take their family out of there. And so that's the example of a moral hazard. There's the other moral hazard, that there was a list of injuries under the Compensation Commissioner's list for occupational injuries. I'm going to hold up my hand, and it said, if you lost a finger on your hand, the baby finger was worth X, the fourth finger was worth Y, the middle finger was worth Z, and then the index finger was worth more, and then the thumb was worth the most. So the person could think, how much money did they need, and cut a finger off their dominant hand or their non-dominant hand. And again, the moral hazard represented. So in healthcare, the moral hazard is that complex combination that processes and technologies intermeshed with what we do as people into a healthcare system that brings both benefits, but also can sometimes result in risks and harm. So the reference to this, for those of you that like to read, is the Medication Safety and Polypharmacy document that was issued by the World Health Organization in September last year, September 2019. When we look at our practices, one of the things that we should be looking at is patient safety, and patient safety in terms of medication errors. Many of you will know, and if you don't, you will know after this comment, that HIV, TB, and malaria are considered the big three in terms of health conditions in the country and on the continent that we need to look at. Adverse outcomes is the 14th leading cause of morbidity and mortality around the world. It puts patient harm in the same category in terms of morbidity and mortality as both tuberculosis and malaria. So if we think about patient safety issues and the outcomes as a consequence of sometimes our best intentions, or hopefully most of the time our best intentions, but sometimes because we were maybe not as good as the reasonable practitioner would allow, it puts us high up in terms of risk. The challenge for us, and that's why we do these CPD lectures, both in ethics and the clinical side, is how do we prevent harm, specifically avoidable harm that comes out of better education or slower consultation or more dialogue or improved informed consent. And so the challenge for us is how do we prevent avoidable harm to patients and by extension to our patients, to their families during their care that they get from us. So the global patient safety challenges that the World Health Organization shines a light on, and specific for this talk, is a strategy called Medication Without Harm. You'll see me reference that below under medication safety in high-risk situations, which was again published last year. So before we continue, and that point of self-reflection that we spoke about, and some of you will have heard me and remember me speaking about Atul Gawande's checklist manifesto. My question for you at this point is, do you have a medication safety checklist for your practice? If you do, as we talk through this, I'd like you to try and mentally cross off, or practically cross off, the comments that we're going to talk about in terms of the medication without harm strategy, the 5 rights as it relates to medication management, medication admission forms and strategies, and other patient awareness steps against your checklist. If you don't have a checklist around medication safety as part of your patient safety strategy, I'd like you to consider saying, what might a checklist look like for those of you that either make use of medicine or medicinal preparations, those of you that prescribe medicines, and those of you that dispense medicines from your practice. So I have a book in my rooms written in 1897 on the medicinal use of cocaine in ophthalmic surgeries. So those of you that are interested, I'll make a copy of it for you and share it with you. So let's have a look at medication without harm, the WHO strategy. They split it into 4 key areas, and each key area has 4 subcomponents to it. And so let's start with the patients and the public. There's a key part around managing medicine that involves patient organizations and advocacy groups. We don't have very strong advocacy groups in this country, or certainly not as strong as we need to have. But those are very effective in helping us understand what patients and their families perceive at-risk medicines and at-risk experiences to be. Equal to that, and possibly you can think about this in the early stages of your practice, is how effective do you have in terms of your patient engagement and reporting by patient strategies, both to yourself or to the pharmacist, that the patient can come back to you and say, you prescribed or dispensed or used this medicine on me, and it made me feel like this, and the outcome was positive, good, or poor. And I think that's a really important key part as we look forward in how we manage medication in our practices. Because equally, do we have, and this is a question that's asked, and you can think about it again in your populations, is do we have public awareness around medicines and their uses and their names, and the difference between an ethical or a generic or an originator or a multi-source medicine? And do our patients have medication literacy? Medication literacy is not only reading the package insert, it's understanding that different preparations, when used in different combinations, have different impacts. And the use of those medicines in ways outside of what's recommended or prescribed can have adverse outcomes. So that's the patient and the public wheel. Specifically for us as private practitioners would be the engagement and the reporting by patients and the assumed medication literacy that we think our patients have. In terms of our own behaviors, there's our education and training on an ongoing basis with how literate we are as individual practitioners, as a practitioner body or a practitioner group, in terms of the medicines that we use. How well do we communicate with each other and other practitioners within the patient's care chain? And we're going to talk a little bit later about transitions of care and high-risk situations as mechanisms of where there are key areas for action and improvement. Then we start looking about capability at our point of care and incident reporting and learning. Do we take enough time within our own practices, and do we have enough capacity to understand and get informed consent from our patients and share with them the information around the medications either that we're using or prescribing and or dispensing? And how, when we get feedback from a patient, if the patient says, I've had an adverse outcome, I used this as a drop and it made me itchy, or it made me burn, or it made me tear, or it gave me blurry vision, or any one of a number of other side effects, made me dizzy, nauseous, disorientated, hyper-stimulated even. How do we record those incidents? How do we report on those incidents? Who do we share that information with? Or do we make a note in the patient's file and we forget about it until we see that patient again? Or possibly the medication rep comes in and we either remember or don't remember to tell them. So that's the area in terms of your role as a healthcare professional in terms of medication without harm. Then we go through and we start looking at product quality and safety, which falls largely outside of where we are. One of the pieces that does impact on us specifically is naming, labeling, and packaging of medicines, because we often assume that we understand the medicine, and we know that one of the biggest medication risks is look-alike, sound-alike medicines or dosage errors, 1.0 versus 0.1. And so how we name and label our medicines is important. How we store our medicines, how we pack our medicines. We had a practitioner fairly recently ask the question, and they said, well, I was stopped at a roadblock during lockdown and I had all of these meds in the car, but they really were for the use by patients, but they were from the hospital pharmacy and they were unscripted. And so, well, what were you doing with them in your car after hours traveling between 2 areas with them in an unsecured box? So the management, the use, the logistics, the transportation of medicines is important. And then also using the right product at the right point of care is important. And so I would ask you if in your practice you've got policies and procedures that look at your naming, labeling, and packaging, that look at the logistics of how you receive medicines, how you record them, how you store them, how you dispose them if they're at expired or end of life, or how you manage your stock control as you dispense or share them, and then how you make sure that you're using the right product at the right point of care at the right time. And that takes me into that final red wheel on the systems and practice of medicine. So do you have good leadership? Governance is really about the oversight and control that you exercise on your practice and that others exercise on you and your practice. What is your prescribing if you're preparing your preparation and your dispensing strategies? What is your administration strategy if you're using this with patients? And most importantly with that, your patient monitoring and evaluation strategies to make sure that what you're doing in the medication component of your practice is consistently good and not only meets and exceeds high aspirational standards, but also meets and exceeds patient safety standards. So I suppose at this point, there are some of you that are saying, nailed it, got it right, well done. Those of you who are not saying that are thinking, I don't know the answer to all of those 32 components of those 4 wheels. There's a good area for reflection. We're going to talk today around 3 things. We're going to talk about pharmacovigilance as a principle. Then we're going to take that into polypharmacy, transitions of care and high-risk situations, which then includes the inappropriate use of medicines in the next component of our talk. Then we're going to go into what the South African regulation and legislation says that we should be doing around prescribing and record keeping. We're going to look at some safe medication patient safety practices, and I'm going to leave you with some ideas to think about. So that's the plan for the next couple of minutes. I see that there's no questions, so I'm assuming everyone is happy. And so let's go on. When we kick off on this piece here, let's understand what we mean by pharmacovigilance and applying this then not only on a national or regional or provincial or local level, but also on a practice level. So pharmacovigilance in terms of a pure definition is there to improve patient care and safety in relation to the use of medicine and all medical and paramedical interventions that are aligned directly and indirectly to the use of that medicine. So if you were to take this back off from the last slide on the systems and structures, is do you have a flow chart or a diagram or an interconnected image that gives the person, including yourself and your patient, a sense of how the medicines will interact and influence your medical and adjacent related paramedical interventions? Of course, it's there to improve public health and safety, and it's there to detect problems related to the use of medicines and to communicate these findings in a timely way. Now, if you look at public health and safety and you look at detecting problems, there are certain studies that are being done by pharmaceutical companies and by health systems where they're looking at 2nd and 3rd generation prescribing, dispensing, and consumption habits. And they're using those 2nd and 3rd generation prescriptions to identify if there was a medication error or adverse outcome from the first line script. And so they're working up the dispensing chain and up the prescribing chain to understand if primary medicines are being used properly or to a less effective therapeutic outcome. And then that, of course, helps to contribute to the assessment of benefit, also to the effect and contribute to the assessment of harm, to look at effectiveness and risk. And when you start looking at a cost benefit, harm, effectiveness and risk basis, you're then looking at the cost benefit analysis. You're saying, is it worth spending this kind of money on this kind of medicine for this kind of patient in this kind of situation? And you'll know as well as I do that that affects funded decisions on whether they're going to potentially pay or not pay for treatments going forward. Pharmacovigilance is also there to encourage a safe, rational, and more including cost-effective way of using the medicine, but not limited to cost-effective, specifically effective ways of using the medicine. And then the last piece, which is a little bit of why we have these discussions today, It's there to promote understanding, education, and clinical training in pharmacovigilance, and its effective communication. So in this case, where we start looking at the effective communication of pharmacovigilance practices to the public, we start asking the question of, are we applying principles of informed consent and disclosure and information sharing with our patients in a way that they can understand the use of the medicines, the reason you want to use the medicines, the impact of that medicine, its potential risks in terms of other medicines that they're taking, and what to do if the outcomes or the side effects are not desirable or adverse. So that's pharmacovigilance on a broad scale. Let's just change gears a little bit and look at key elements as it relates to medication use within the context of the South African environment. So when we talk about the context of our environment, of course, we're going back to the National Health Act, and out of that, we're looking at the Health Professions Council of South Africa's ethical guidelines booklets. All of you have heard me speak about these booklets before, but if you haven't for some reason, you should have downloaded by now, and if you haven't, I would strongly suggest and recommend that you download the ethical guidelines book. It's a mere 334 pages that contains all of the booklets in it. And whilst we speak lightly about it, you should know all of the booklets and all of the chapters in each booklet because it relates directly and indirectly to your practice. So when we start talking about any of these elements of medication use or any of the elements of practice, of course, we need to talk about booklet 1, which talks about your ethical responsibilities as a practitioner, and booklet 2, which expands on that in terms of specific issues. And they talk about your ethical conduct to your patient, your ethical conduct to your colleagues, your public responsibility as a practitioner, regardless of whether you're in the public or private space. But as we go through medication use, they also talk about informed consent, confidentiality, disclosure, and record keeping, and they talk about the importance of information that you share. So your patient information as it relates to medication use needs to, at the very least, align itself to booklets 4 on confidentiality, on informed consent, booklets 5 on confidentiality and disclosure, and booklets 9 on patient record keeping. I know you know all of that, but just in case you didn't, I'm reminding you. Also, all the information that you share with your patients, in addition to the consent that you need from them, you need to bear it in mind in terms of booklet 5, how you share information, what that information looks like and how it's recorded. The definition of communication is a delicate one, and we know, and we reflect on this when we look at medical errors, and we reflect on this when we look at the levels of litigation or the risk towards litigation, that adequate communication is most often the reason why practitioners end up in a difficulty with patients. Now, whilst I use those terms, I don't really like them because it's why you as a person are in a dispute with another person who you provided care or services to. Because a dispute is two people who have a different view of the same or different perspective of the same experience, which incidentally is called a qualia, Q-U-A-L-I-A, a different experience of the same, a different interpretation of the same experience. So when we look at communication in terms of medication use, we talk about the S-bars. What was the situation? What is the background to that situation? What is the assessment that you made off the back of that background? And what are the recommendations that you made? And all of those need to be recorded in 2 levels of communication. They need to be recorded in terms of what you write down for your own records, and they need to be recorded in what you share with your patient. And that should include, if you've got drug packaging, labeling, and the nomenclature that goes around it. It should include your drug device acquisition and use and monitoring, if there is a drug device that you're using or any other medical device adjacent to the use of those medicines. You need to also consider the environmental factors, both in terms of your responsibility to your patient, your responsibility in terms of public safety, your responsibility in terms of your colleagues and how you communicate with them, which is the HPCSA booklets 1 and 2. You also need to think about how medication use impacts with your staff education and their competency. If you're making a recommendation to a patient and the patient calls back and speaks to your practice administrator or your practice nurse, have you educated them Do they have access to the records? Do they know the medicines? Are they literate in the side effects? Do they understand what's going on? Equally, and we spoke about this in the wheel earlier, have you educated your patients sufficiently for them to make informed consent firstly, and for them to understand the implications secondly? And then finally, in terms of how you manage medication use in these 9 criteria, is do you have a quality process and have you run a risk management framework so that you can understand what could go wrong? Could you, and do you, and might you have a quality process and a response that if you provide medication as part of an in-room procedure and there's an anaphylactic reaction, do you have the necessary interventions? Do you have the antihistamine? Do you have the adrenaline? Do you have an AED? Do you know how to use the AED, let alone everything else that goes with it? So those would be part of your quality processes and your risk management strategy. So on that cheerful note, and as we start thinking about where to go from here, I'd like you to consider and test yourself on the 5 rights of medication administration. And I should have maybe asked you the question before I put the slide up, because now you look at it and you say, yes, you know it. But do you know, and do you have a record of the 5 rights? The right patient gets the right medication in the right dosage, at the right route, at the right time. Now, I put this in here because medication errors happen. And sometimes the right patient gets the right medicine in the wrong dose. Sometimes they get the right patient gets the right medicine in the right dose with the wrong route, or they get everything else right, but they take it at the wrong time. So they get their meds mixed up, and the ones that they take, which are sedatives, they take in the morning and then they're drowsy all day. And the one that they would have taken as a stimulant, they take at night and then they can't sleep all night. So these things happen, and not only do they happen because the pharmacist gets it wrong, it happens because the patient gets it wrong. They've got 2 bottles, they forget which one is which. They've maybe decanted the medicines out of the prescription bottles that they've, or blister packs that they've got, and they've put them into their own daily medicine storage devices. You know, those that go Monday, Tuesday, Wednesday, Thursday, Friday. They've got the AM and PM tabs confused. So the question I would ask you in this case is, do you have a 5 rights list? And do you keep a medication administration record for each patient that says, and you keep it in their file, and maybe you share one with them, that says you as a patient are getting these meds at this dosage, at this route, so intramuscular or droplets or capsules, at what time of day and how frequently. So those are the rights. And my question around the medication administration record is, do you have one for your practice? Do you have one for each procedure? Do you have one for each patient? The answer is no, and you were striving towards a higher level of safety for indemnifying yourself against medication risks, this would be one of those things that one might look at. Startlingly, when we look at adverse outcomes in wards and in hospitals and in outpatient clinics, we see that these 5 rights in this order are often missing, or the people that we ask about them often leave one out. They leave out the dosage, or they leave out the route, or they leave out the time. So this is a very good test for you to, as you seek consent from your patient, say, have I spoken to the patient about their medicines? Are they listed? And then you go down the route with the right dose, with the right route at the right time. So if we look at some of the broader medication challenges that a country faces or an institution faces, there are some there that we're not going to talk about today, like substandard and counterfeit medicines. We're not going to talk about donated medicines. Although if you work in a facility like a care home, I have the pleasure, and it really is a pleasure, to sit on the board of hospice. And one of the challenges that we find in the pharmacy that we have in our hospice is that we get a lot of donated medicines. Now, a lot of those donated medicines are not a lot, but a significant amount, maybe not appropriate for the kind of patients we see. They may be not packaged appropriately. They may be very close to end of life. They may already have been expired. So how you manage medicines, or how you're aware of the use of donated medicines, is critical. Equally, and it's at the end of this list, and we're not going to talk about it a lot, but it is worth knowing, is informal distribution channels for medicines. Pain medicines, benzodiazepines, antipsychotic medicines, eye drops, steroids, non-steroidal anti-inflammatories. They're often shared between people, and you say, oh, my eyes are really sore, and I say, oh, you know, your eyes are sore. I've got this great eye drop that my doc gave me. Why don't you try these? And I don't know that they maybe have a very specific formulation to them, which may or may not act poorly with somebody else. And not being a user of eye drops on a large scale, not wearing contact lenses, I remember putting in the wrong eye drop at night because my wife at the time had saline, but she also had the preparation to remove the protein from the contact lenses. So you can imagine in the middle of the night, my less than delightful screech of putting the wrong preparations into my eyes. So informal distribution channels are very, very risky, and in your environment specifically can have profound effects. So we're going to talk a little bit now about polypharmacy, because that is one of the known biggest risks, and it is certainly something that would affect yourselves. We're also going to reflect now on the incorrect use of medicines, and I'll share one or two examples. Both in terms of polypharmacy and the incorrect use of medicines is the risk of interactivity between and with medicinal preparations. So bear in mind that whilst you might be diligent in your prescribing habits, your patients might be buying over-the-counter medicines that they might have forgotten to tell you about. They might be getting medicines from other practitioners, both in the allopathic or allied ranges where they are dispensing preparations, and these could have a significant impact on your best therapeutic intention. So the definition of polypharmacy is conventionally, polypharmacy has been perceived as an overuse of medicines, but and that would be to have more than 4 or 5 medicines being used concurrently. Although the definition is now changing to consider more, how do we look at polypharmacy in terms of its appropriateness of the use of those medicines? Because there are many cases where the concurrent use of multiple medicines may be necessary. There are others where they may be beneficial. So it's not that polypharmacy in its own right is poor. It's whether the appropriateness of the medicinal preparations and the concurrent usage of these medications over a duration of time should be good. And when we looked earlier on at that wheel, I spoke about the need for communication and education between practitioners. So to what extent should we involve other professionals in our patients' care? And I use that phrase because I often hear practitioners talk about my patient or my patients or the patients of my practice. But these are individuals who we are the service providers of. And if you look at patient-centric care, if we are providing care and there are potential metabolic side effects, should we be speaking to that patient's primary care doctor? Should we be speaking to the other clinicians or healthcare professionals who that patient is seeing and who may or may not be part of the dispensing and prescribing protocol or therapeutic landscape of that patient? So I ask that because if I were to say to you, do you have in each patient's file a network of their other practitioners who they see on a semi-regular or regular basis? Do you have a list of all of their chronic medicines that they're taking, in addition to or adjacent to the medicines that you've prescribed or that you prescribe for them on a regular basis? And have you communicated your treatment regime, your medication treatment regime, with the dispensers, prescribers of those other preparations? So you'll know the answer to that. Maybe you do, maybe you don't. Of course, now, because we're in an environment where we're not seeing our patients as often and we're doing more telehealth and telemedicine interactivity, we might not be giving our patients enough airtime to ask them these questions. We might also have known about this before, but because of COVID, because of the lack of potentially the continuity of care that goes with it, our patients may have stopped some of their treatment regimes. And if they've stopped a chronic medicine and haven't told you about it, it may have a material effect in terms of your treatment decision. It may not, but it might. So I use this because this is a true example that came out of the physician ordering one medicine, the pharmacist prescribing a second medicine, and ultimately it results in the diabetic ketoacidosis and the child dying. And so these medical errors still happen. This is an example from 2006, but I can tell you from a hospital I was a risk manager in 2012 to 2014. This was common then. It was common in practices that I've reviewed as recently as last year. So the legibility of what we write, the appropriateness of what we prescribe, and the effectiveness of what we follow up post-prescription in the day and weeks subsequent to our patient being discharged from our immediate care plays a key role in how effectively we use medicine. So here are some of the most common causes of the incorrect use of medicine, which are fairly well known, and none of these should be a surprise to you. We've spoken about the use of too many medicines per patient, in other words, polypharmacy. The inappropriate use of antimicrobials, often in the wrong dosages and often for non-bacterial infections. If you're giving an antimicrobial for a viral infection, you're likely to not get the desired outcomes. So I worked in a hospital for a while and was deeply distressed that vancomycin was their first line of antimicrobial, because where do you go from there? Then you've got the overuse of injections, where you could use oral formulations. The challenge always, and I would ask you to think, those of you that are my age or slightly older, none of you are older than me, but if you were, I remember I had two books when I graduated. One was the Merck Manual, which was a 2-inch thick book, and it had thumb indentations and onion skin paper. It was a beautiful book. I've still got my centenary Merck Manual from 1999 with its original centenary publication from 1899. The 1899 book is about as thick as my smartphone, so not very thick at all. The 1999 book was as thick as my fist. But in addition to the Merck Manual, there was a MIMS, which was the prescribing book, so I could look up medications, I could look up their doses, and I could look them up in terms of clinical guidelines. Nowadays, we don't really use desktop publications anymore, but you would have a desktop in terms of a laptop or a smart device, a subscription to the equivalent. So I'm hoping you do have that, and I'm hoping that you use your clinical guidelines in accordance with that. Maybe that's one of the things for your checklist, is to say, do you use a clinical guideline? Do you use an electronic reference tool? And are you cross-referencing the medicines that the patient discloses that you've probed them on with the medicines that you're considering prescribing and or using? And have you looked at them in terms of the appropriate clinical guidelines? Then the question is, have you checked for inappropriate self-medication? And self-medication is, well, I've kept my meds from my last infection. I didn't finish the antibiotics, I'm going to use them now. Or I didn't finish the corticosteroids or the steroid cream or the eye drops. I've kept them somewhere, they're in one of the drawers, and I'm just going to use them now. And then the interaction between, and we spoke about this a little bit earlier in this conversation, between alternative and modern medicine and how those hang together. So the example here is St. John's wort, but an example that I could give you was the use of arnica. And arnica, people would take, especially the late 90s, early 2000s, they were taking huge doses in preparations such as Traumiel. And then they'd get into a surgical environment and they would bleed, and they would bleed in excess because the arnica creates bleeding, and then it was difficult to manage that. They hadn't told the clinician about it because that was an alternative medicine. They weren't taking medicine, they were taking a preparation. And so how you ask the questions around what tablets people are putting in their mouths, what preparations they're using, I think is an important part of managing medicine in a more safe space. Let's change gears a little bit here and start asking the question, what would we define a high-risk situation to be? We spoke about polypharmacy as being one, high-risk situations being a second, and transitions of care being the third strategies to address in terms of medication without harm. So here, we recognize that a high-risk situation is more often associated with significant harm due to unsafe medical practice and medication practice. Also, in a previous talk, I've spoken to you about the two types of error that we can make in treating a patient. The first type of error is the error by commission, something that we've done. The second type of error is an error by omission, something that we've neglected to do or something that we've left out. So in a high-risk situation, the risk of an error by omission or by commission goes up significantly. One of those is the use of a high-risk or a high-alert medicine, a medicine that has a potentially low therapeutic index, in other words, a low ratio of that maximally tolerated dose to the minimal curative or effective outcome. So using the right medicine at the right time is important. Over or under prescribing or misprescribing, which can be a result of a distraction or a lack of awareness from the practitioner, or a lack of disclosure or a lack of understanding from the patient, or a lack of sharing, can result in that second high-risk environment. And then systems factors. We're in that space, and we spoke about it now, of using telehealth. And because of telehealth, maybe the connection is not as good, maybe the clarity of the dialogue is not as clear. Your patient load may have changed. You may have a sudden high pressure. You may be working in an ambulatory clinic or an outpatient department. The work that you do ward-wise or in the hospital. COVID, unquestionably, amongst others, these are high-risk situations, and within these settings, added to a patient and provider pressure, added to potential environmental and social stresses, added to the availability of medicines, can often get you into a difficult position. Speaking this morning, we were looking at healthcare in Zambia, and it reminded me of a story of medication. I was in rural Botswana. I worked with and for a non-profit group called Mudiro. What Mudiro does is they go out into rural Namibia and northern Botswana along Kongola and Caprivi and that area, and they provide access to care, which includes medication management. And talking to one of the people in Botswana, I said, well, how does it go here? What's your formulary look like? What kind of dispensing do you do? He says, well, we use the paracetamol cure. If somebody falls out of a tree, paracetamol. If they've fallen off a ladder or they've hurt, why? Because we've owned paracetamol. So access to the right medicines and the right formulary and the right dosages at the right time is a key stressor in what does often cause a high-risk situation. So the final piece of high-risk situations is transitions of care. And transitions of care are multiple and they're complex. So when we start looking at transitions of care, we need to start looking at a long-term commitment from healthcare leaders, yourselves, and cohesive efforts to reduce patient harm. So one set of transition of care is when 2 or 3 or 4 people are seeing the same patient. The patient may have a general practitioner, they may have a homeopath, they may have a physician, they may have a cardiologist, they may have a person treating their diabetes, and they may see you. Now, across that transition of care, there's the continuity that's needed in order to create a formal structured process to reconcile medicine. Not only to reconcile medicines, but to reconcile all aspects of care. So the question would then be in terms of managing transitions of care. If you look at your average patient and you look at the patients you see every day, how many transitions of care does each of your patients have in a 1-month period? Now, do you have within your file or your notes, either written notes or in your electronic notes, a transitions of care block that shows who your patients are transitioning their acute, subacute, and chronic care through on a regular or relatively informal basis? And part of that then is important in terms of getting what's called your BPMH, your best possible medication history. So you would need to then start to say, can you get a history that's medication based? How often do you reconcile that medication list, and how often do you update that list? And in addition to updating that list, how do you communicate the importance of this list, both with the patient and with other healthcare providers around changes in medication? So if you're changing a patient's medication regime, and changing also includes introducing a medication, we're going to talk about that on the next few slides, do you have a standard communication form that moves through transitions of care? And that not only moves through, well, the patient was admitted either into your rooms or into an ambulatory care environment or into a hospital environment. They receive their care, they transition out, they get discharged, and then they get discharged from your care for that condition. Those are some of the transitions of care. But also, as they go in and out of other care, while they're still on a acute, subacute, or chronic medication regime of yours, they are still considered to be transitioning through your care. So you may want to consider how you might map that and how you might look at it. So the Cartlet psychiatric report generated quite an interesting food safer prescribing model that I'm going to share with you now. I've also aligned this prescribing model to the HPCSA booklets 4, which is on informed consent, 5, which is on information disclosure, and 9, which is on record keeping. The first of those steps is for you as the clinician to develop and document a clear rationale of why you want to use a medicine or combination of medicines, given the risks that they present. Now, those risks could be risks to patient in terms of adverse outcomes or side effects or complications, but also drug interactivity with other acute or chronic medicines that patient might be taking. That's step 1. Step 2 is once you've reached your diagnostic opinion and decided what you want to do, how have you engaged with your patient in an informed discussion about your recommendation and what alternative options there are? Because we know, both in terms of booklet 1 and in terms of booklet 4 on informed consent, it's the patient's choice what treatment the patient accepts. It's not your choice. But if the patient accepts a treatment and there's an adverse outcome, the patient is not going to likely acknowledge that it was their choice. They're going to say, I trusted my practitioner who gave me bad advice. And we all know of situations where that's happened that haven't led to a formal dispute, but we also know of situations where it's happened where it has led to a formal dispute. And so understanding your diagnostic rationale, understanding what you want to do and why you do it, communicating it to the patient and recording it are the first 2 steps of safer prescribing. The third step of safer prescribing is how do you monitor that patient closely enough to understand whether there are side effects, and if there are, how do you step in? And if you step in, do you lower the dose? Do you stop the meds? Do you continue the meds to see if the side effects begin to fade? Now, you can't do that if you don't have a structured monitoring post prescribing regime. This goes back to me asking you earlier, what is your regime for your patient? You follow up with them the next day after they've been on the meds for 12 hours, 24, 48, or 72 hours to understand whether there's efficacy to your treatment and whether the patient is happy, unhappy, progressing, thriving, or having an adverse response. So the WHO speaks about 5 moments of medication safety. And I raise this here because the question I suppose that I would ask you is, do you have a checklist for each of these? If you're starting a patient on a medication, do you have a checklist on how to start them? Do you have a checklist for them on how to take their medication? And you may think, well, it's the pharmacist's problem on educating them on how to take the medicine safely. But up the accountability chain, the pharmacist will say, yes, I gave the medicine to the patient, and on the side of the medicine it was written, take these 3 times a day. But ultimately, you as the prescribing practitioner have a therapeutic relationship with that patient and an accountability to making sure that they are taking their medicines appropriately. If you're adding a medication to their existing regime, you have additional accountability. You also have an accountability to reviewing the medication that they're taking in terms of the appropriateness. And if you're going to stop their medicine, how do you titrate that medicine? It's either got a limited time that you're taking it for, it's an acute med. If it's subacute or chronic, and there's other drug interactions that you need to take into account, stopping the patient's medication is key. So you may want to share with them the journey that they go on from starting to taking to adding to reviewing to stopping their medication, and what the risks and compliance requirements are at each of these steps. Then I put the slide up, and I used to call this the medical alphabet, but I do still regard that legibility is key. The legibility in your prescription, the legibility in your records. If you can't read your own writing, you can be sure that no one else can read your writing. And as much as I joke and say, this is how we all got into medical school, we hand wrote our applications, and if they could read it, they threw it out. Those days are long past. I still see scripts and I still see patient records today that are illegible. I even see patient referral notes where a practitioner has referred somebody to come and see me, and I look at it and I say, I'm not really sure what this person means. Left and right are confusing. A and O are confusing. C and D look the same. So have a look at this and ask yourself the question, are you really being as diligently legible as you could be? You either are or you aren't. And if you're not, this is the time to pause for thought. So in terms of issuing prescription, there are two things that you need to know here. You can use typewritten, computer-generated, pre-typed, pre-printed, or standardized prescriptions for medicines of schedules 1 through 4. But medicines scheduled 5 through 8, you are still required in terms of booklet 9, section 7, referencing rule 17, you're required to issue handwritten prescriptions for your higher schedules. Now we go back to the previous slide. If you're issuing a handwritten prescription, please make sure it's legible. It needs to be legible, and it needs to have your original signature on. Bear in mind also with patient records that you need to legibly have for each patient written down, and this is booklet 9 again, section 4, you need to have the proposed clinical management of that patient. It needs to include the medication and dosage prescribed. It needs to include, according to the booklet and according to your safe clinical practice, your patient's reactions to the treatment and or the medication, including adverse effects. Now, if you're not following up with that patient 1 to 2 to 3 days post-discharge or post them filling their script, how do you know to make a note that the patient is having an adverse effect? The only way you might know is when the patient doesn't come back and you get a request for records a month or a year or several years later because the patient is discontent. So as we sum this up, because we're coming up to closure time, 2 more slides. The first says, and what we see here, document everything. Document your medication labeling. Make sure it's legible. Record the administration of medicine, because the lack of proper documentation for any medicine can result in an error, and that error, which could be an error of omission, is an error of lack of follow-up. Make sure that reading the prescription label and expiration date is a best practice, especially if you're dispensing medicines from your rooms. And you can sometimes, and it sometimes happens, that the correct medicine could be have an incorrect label or be in an incorrect box. And that is also considered to be a medication error. So here's 10 strategies which are straightforward, and we've gone through all of them today. Know the 5 rights for medication administration. Follow proper medication reconciliation procedures, and if you don't have them, implement them. Double and even triple check these procedures and make them part of your clinical checklists. Have somebody read it back to you so that you can check it. Where necessary, if you're working in an institution, having another physician or nurse read it back to you and doing name alerting is really important. This one seems simple, but strangely enough, a lot of people don't do it. Don't put 0.25. If it's 0.25, make it 0.25 so that the dosage is quite clear. Document everything. Make sure that you've got the right storage for medications, and make sure that your patients have the right storage for medications. If you're working in an institution, understand what the medication administration policies, regulations, and guidelines look like. We spoke about this with MIMS a little earlier, and I use that as the book of choice of the time, but consider having a drug guide available at all times. And what is your drug guide? And do you have it available? And is the subscription up to date? And so I call this my medication errors risk universe in terms of priority actions, high risk situations, route to the patients, and transitions of care. So understand that you need to understand what your high risk situations could look like, what polypharmacy risks you may or may not have in your practice, what transitions of care involve you and your patients and other practitioners. In terms of high risk situations, are you seeing a lot of inpatient work? Are you seeing young children or the elderly? Nowadays, that would also include those with morbidities and comorbidities and COVID-related risks. Is there a risk of administering the wrong dose in the practice that you do or using the wrong route? Is there a risk of you or your patient not following their treatment regime? Understand with polypharmacy that we're looking at least 4 to 5 medicines, plus over-the-counter medicines and the use of other prescription meds. Understand that polypharmacy does have an increased risk of side effects and an increased risk of drug interactions. There are complications with adherence. Look at transitions of care. As the patient moves between facilities, sectors, and healthcare practitioners, there are always in transitions of care risks of communication error. Consider how you prescribe, how you transcribe, how you dispense, and what the administering and monitoring practices are that you have both in your practice and that you share with your patients for themselves. Understand that weak medication systems, human error, fatigue, staff shortages, and adverse drug interactions do cause medication errors and harm to patients. Appreciate that those 5 moments that we spoke about, from a patient starting medicine to the patient ending medicine, is important. Try and encourage adherence and empower the patients and their family. And in doing that, you'll develop a functional status for them. Also start looking at patients and the public and the medications that they're taking, the relationships that you have with them and other healthcare practitioners. And also try and ask yourself, do you have the systems and practices for medication management, for your practice, for your patients, in as robust a way as possible? And at this point, I'm going to say thank you very much. You've been listening to me for an hour with no questions. So I'm not sure if I've just overwhelmed you or if you decided that it was a no question Wednesday. But Johannes, thank you very much for giving me the opportunity. And MJ, I'm going to hand back to you right now.
Thank you, Brad, for an engaging talk as always. I think perhaps you were just incredibly thorough and covered all of the questions that the practitioners may have. Doctors, for any of you in the room who may have some questions for Brad, in order to unmute yourselves, please just hold your space bar down and you'll be able to address any questions to him. So we'll keep the room open for a couple minutes to allow you to do that. Whilst that's happening, I'll just fill you in. There's a 1 CPD point that is allocated for this event, and you'll be contacted in the coming days to have those sent to you. So yeah, this is over to the floor if anyone has any questions. Alternatively, we'll wrap up for the evening. Brad, it looks like you're getting off very lightly this evening, hey? No one, it might be the cold blimmin' winter evening and everyone's just wanting to get to a hot dinner and a glass of wine to wrap up the evening. So with that said, thank you once again for all of you that were in attendance. We hope that you enjoyed the event. Please, will those of you who can see the screen currently being shared, follow us on LinkedIn, or alternatively like our YouTube page so that you can be kept informed of future CPD events that we will be doing. So the details are on the screen, and as I say, we'll leave it for about another 30 seconds and then we'll close off for the evening.
Thanks, everyone.
Brad, there are a
Really
lot of
appreciate it.
there are a lot of thank yous coming up on to me privately. So I think the practitioners genuinely did enjoy your event, or enjoy your talk.
Thanks, MJ. Thanks, Johannes, and thanks everyone for being here. Really appreciate you giving your time.
Alrighty. Well, with that said, thank you very much, practitioners. Have a great evening, and we hope to see you at future events. Enjoy the rest of the evening. Thanks, Brad. Thanks, Dr. Serpentine.